Hello, my name is Alfred Abuhamad. I am a maternal fetal medicine physician in Norfolk, Virginia, and I'm honored to be part of the meeting today. I would like to thank the Society for inviting me to speak. And my first talk is on the top anatomic regions in the fetal heart. I am hoping that during this presentation, I will share with you 4 critical anatomic regions that I believe will allow you to detect most fetal cardiac malformations. So the first important anatomic region is the normal left atrium. So if you look at the 4-chamber view, and you see that the left atrium is the most posterior chamber, sits right over the spine, and receives the 4 pulmonary veins, 2 superior and 2 inferior pulmonary veins. And this anatomic region right here, the left atrium and the area behind it, is very critical in the evaluation of the 4-chamber view. At the level of the 4-chamber view, you see the 2 inferior pulmonary veins coming in. With the coloring techniques that we have today with color Doppler, you can now see not only the 2 inferior pulmonary veins in the 4-chamber view, but also on occasions the 2 superior ones, as you see here, the 2 right and 2 left pulmonary veins coming into the left atrium, and novel technology that detects flow in the arterioles and capillaries allow you to see the whole pulmonary venous tree as it is connected to the left atrium. Now, why this area is of critical importance? So what I want to stress upon you is the evaluation of this anatomic region right here. You have the descending aorta, the esophagus, which is when closed, appears as an echogenic dot, and then the 2 inferior pulmonary veins connecting to the left atrium. Anatomically, you see this area here with the proximity of the azygous vein to the descending aorta. And here on the 4-chamber view, you see this critical area here. That's the azygous vein, descending aorta right here. Now, why this is an important region? First, the normal anatomy, as I showed, involves the 4 pulmonary veins draining into the left atrium. In total anomalous venous return, the most common type is the supracardiac type. Here you have the 4 pulmonary veins draining into a confluent vein that sits right behind the left atrium. And then a vertical vein takes the blood up to the brachiocephalic vein to come back through the supravena cava to the right side of the heart. And that is the most common total anomalous venous return. The second most common is the infracardiac type. You have the 4 pulmonary veins draining into the confluent vein. And then there's a vertical vein that goes into the liver, and through connections in the liver, the blood returns to the right side of the heart, primarily through the IVC, but could be through other channels also. And the least common total anomalous pulmonary venous return is the 4 pulmonary veins drain into the confluent vein that connects through the coronary sinus to the right side of the heart, or directly drains into the right atrium. What all they have in common is that confluent vein that sits behind the left atrium. Now, you have to be careful not to mistake that confluent vein with a dilated esophagus. So the esophagus, when it's closed, appears like an echogenic dot between the aorta and the left atrium. But when the baby swallows, it appears like an extra vessel here. But typically, this opens for 2 or 3 seconds. So if you watch a little bit carefully, certainly if you put color Doppler, you will know that this is not the vessel. And again, here's the closed esophagus. And here's with the fetus swallowing, you see that the esophagus is filled with amniotic fluid for a very short period of time. So learn where the esophagus is and the anatomy of the esophagus when it's closed and when it's open. Now, here's a supracardiac type total anomalous venous return. I want you to look at this clip right here and notice first that there's ventricular disproportion. Notice that the right atrium is larger than the left atrium. But also, if you can see this very thin confluent vein that is sitting right behind the left atrium, and I retrieved from this clip this still image to show you this confluent vein. But also note another important anatomic feature of total anomalous venous return. The distance between the descending aorta and the back wall of the left atrium is increased when there is total anomalous venous return. Here's the cardiac type. You see the left and right pulmonary veins drain directly into the right atrium. And this is the infracardiac type. They're coming to the confluent vein, and you could see that the heart is significantly abnormal here with a single ventricle type. And then there's a vertical vein that leaves the heart going towards the liver and then returning through the IVC not shown here. There should not be any vein that goes opposite direction from the heart, away from the heart. So when you see that, you should be suspicious of malformation. So what are the clues to make a diagnosis of total anomalous pulmonary venous return? The first and most important is the increased retroatrial distance. So here's the normal four-chamber view with the descending aorta. Look how small that distance is between the descending aorta and the left atrium. And this is a fetus with total anomalous pulmonary venous return. That distance is increased. There are normograms that have been developed, but I subjectively look at this area. When I suspect it's increased, I evaluate much more carefully. Second is there is the venous confluence that is sitting behind the left atrium. As I showed you, here's another case. Significant cardiac malformation, looks like a single ventricle cardiac malformation, but you see the confluent vein and you see the increased retroatrial distance. And the third important feature is an abnormal pulmonary venous Doppler. If you learn to do Doppler of the pulmonary veins on normal babies, you will get a tracing like this. It's a biphasic waveform. During the atrial contraction, there is forward flow in the normal pulmonary venous tree, similar to the ductus venosus. And when there is total anomalous venous return, because of obstruction to the return of the pulmonary veins through the malformation, you will have abnormal Doppler tracings. And this is one way you could see. Other ways you could have even almost a straight line. So these three features are very important to the evaluation of the area behind the left atrium. Now, there are additional features that are due to the physiologic changes. There will be increased flow to the right side of the heart because all the pulmonary venous return is coming to the right side. So there will be ventricular disproportion, as you see here. The aorta will be smaller than the pulmonary artery because, again, all the blood from the pulmonary venous system is coming to the right side of the heart, coming out through the pulmonary artery as opposed to the aorta. And if you have the supracardiac type, which is the most common, you will have a dilated brachiocephalic vein because, as I have indicated, the blood goes from the confluent vein up through a vertical vein to the brachiocephalic to come down through the SVC. And if you have the infracardiac type, you will have a dilated IVC, as you see right here. So these are the important features physiologically of the total anomalous pulmonary venous return. And also, they are listed on this slide. I won't go into details, but what I have discussed is listed here, again, to show what physiologic changes you see at the level of the four-chamber view. So do not miss the diagnosis of a normal left atrium, given how critical and important it is to the evaluation of the pulmonary venous system. The second top anatomic region I want to talk to you about is the normal left ventricular outflow. So if you look at this schematic drawing of the valves of the heart, you see that the blood that is entering the mitral valve comes out from the aorta with a direction of blood flow towards the right shoulder. And blood that is coming through the tricuspid valve comes out of the pulmonary artery, angling towards the left shoulder. So they are both outflow tracts as they emerge from the heart are in perpendicular relationships to each other. So what is the normal anatomy of the left ventricular outflow tract? First, there are three important anatomic pearls I want to share with you. The first one is note the angle between the ventricular septum and the ascending aorta. So here you see that the left ventricular outflow tract, the 5-chamber view, there is a slight angle between the ventricular septum and the ascending aorta in the normal conditions. And you see on an anatomy specimen also that angle. And you see right here in this clip, the normal angle that exists between the ventricular septum and the ascending aorta. Why this is important? Because when you don't see this angle between the ventricular septum and the ascending aorta, you should think about an aortic override. In the presence of aortic override, you lose this angle, and that should increase your suspicion that there is aortic override, and then you should evaluate for the presence of tetralogy flow or double outlet right ventricle. The second important anatomic feature is that no blood flow should come from the right ventricle into the ascending aorta. So if you look at the blood flow coming from the left ventricle into the ascending aorta in the 5-chamber view, you should see no blood flow coming from the right ventricle into that ascending aorta. That is important because any blood flow that is coming from the right ventricle into the ascending aorta on color Doppler make you think of two things: aortic override in cases of tetralogy of Fallot or double outlet right ventricle, or perimembranous ventricular septal defect. And here you see blood from the right ventricle coming through the ventricular septal defect into the ascending aorta. And that is important because this is an important sign. It's called the Y sign. That Y sign on color Doppler makes you suspect the presence of aortic override and is important for the initial evaluation of fetuses with tetralogy of Fallot, and is very important in early gestation. So it is an important sign that helps us suspect the presence of overriding aorta and tetralogy of Fallot in the first trimester. And here you see there's an abnormal cardiac access. I will talk about that later. And a Y sign that makes us suspicious there's tetralogy of Fallot here. Tetralogy of Fallot, as you see here, is a very complex malformation that have many different features that are listed on this slide. What is really important as you evaluate tetralogy of Fallot, you look at an overriding aorta, you should look for the pulmonary artery. If it is arising from the right ventricle, look at the size. If it's small to moderate, then you confirm tetralogy of Fallot. And then here you look at the 3-vessel trachea view. That helps you differentiate, is it pink tetralogy of Fallot? There's forward flow in the pulmonary artery. Is there reverse flow in the pulmonary artery? And this baby will become sick immediately after birth, what we call blue tetralogy of Fallot. Is the aortic arch right-sided? Important for DeGeorge. And if the ductus arteriosus present or absent. If the pulmonary artery comes from the right ventricle but is very small, think about pulmonary atresia with VST. If the pulmonary artery comes from the right ventricle but is very large and you have overriding aorta, think about absent pulmonary valve syndrome. And if the pulmonary artery comes from the overriding vessel but not from the right ventricle, then you have common arterial trunk. So this is the way we evaluate an overriding aorta, using the help of color Doppler. So the third most important characteristic of the left ventricular outflow tract is that the left ventricular outflow tract should not divide in the axial or transverse planes. So if you look at the ascending aorta does not give any branches before it becomes the aortic arch. So when you have an axial plane and you look at the LVOT, this vessel right here, the aorta, you should not see any branching coming out. And that is really important, because whether you're looking at it from an apical, from an axial, or from a basal view, these vessels should not show any branching. That is really important. So not only evaluate the aorta here to make sure there's no override, but follow it into the upper chest in the axial plane to make sure it does not give any branches. So if you see any branches coming out from the LVOT, this is then the pulmonary artery, and you have the diagnosis of transposition of the great arteries. And here's another example on color Doppler. You see the left ventricle, the vessel coming out is giving out a branch. This is the left pulmonary artery, confirming transposition of great vessels. Now, there may be some rib shadowing sometimes, and it's really hard to see. This is why you have to have a high index of suspicion when you look at the LVOT. And I always tell my sonographers, you need to make sure you follow it all the way up, because from this clip in the 3rd trimester, I showed you where the vessel divides. It's a very, very small area right here that you can see it. So that's really important in your evaluation. So when you look at the left ventricular outflow tract, follow it. It is not always easy to see the division, but you should have a high index of suspicion. Let me show you 2 cases to highlight how important this is. So this is the left ventricular outflow tract. Now you can look at this and say, I see the division very clearly. I am very suspicious of transposition of the great arteries. And then if I look at the 3-vessel trachea view, because the aorta is on top of the pulmonary artery, here I see only a single vessel, which is the aorta at the 3-vessel trachea view. Diagnosis is detransposition of the great arteries. Here's a second case. 4-chamber view looks normal on color Doppler. I'm going to show you the 3-vessel view here, and you see the pulmonary artery dividing anterior to the aorta. That is anterior to the superior vena cava. Looks normal to me in this case. If you look a little bit closer and you look at the vessel coming out from the left ventricle, you see that that vessel is dividing. And that tells me that this is the pulmonary artery coming out of the left ventricle. And this is a case of transposition of the great arteries where the vessels are side by side, which is a very rare case in about less than maybe 7 or 8% of all transpositions. But the 3-vessel trachea view will be abnormal. The only abnormality will be the 5-chamber view. So this is why it's really critical to have a very good eye looking at the 5-chamber view in its evaluation. Now, as I mentioned, in transposition, the 3-vessel trachea view is commonly abnormal, but not always, as in the case that I've shown you. Rely on the left ventricular outflow tract, because it's always abnormal. By definition, it will have the pulmonary artery that shows branching. So what about other planes? So when you look at the orientation of the great vessels, you see the long axis of the pulmonary artery with its division. Here's the right pulmonary artery, the ductus, and the aorta is on cross-section. In the presence of transposition of the great arteries, the vessels are in parallel orientation, and you see them both in cross-section like this. And if you go to the oblique view, you will see that the vessels are parallel as they come out of the respective chambers. However, as you see here from the number of ribs, this is an oblique plane that we typically do not get in our evaluation of the fetal heart, in our cardiac screening. So to get to this plane, you should be suspicious that there is transposition of the great arteries. This is why it is really important to look at the 5-chamber view and learn how to evaluate the 5-chamber view well, because that is key to your ability to make the diagnosis of transposition of the great arteries. So do not miss the diagnosis of a normal left ventricular outflow tract. Really important. The third anatomic region I'm going to talk to you about is the cardiac access in early gestation. Now that the 1st trimester ultrasound has become really common and has a lot of value in detecting fetal malformations, looking at the cardiac access in early gestation is really important. This is data from the 1987, looking at the cardiac access in the 2nd trimester. And you could see that the cardiac access in the 2nd trimester does not change all the way to term, with a range of 45 degrees plus or minus 20 degrees. And you could see that when you look at cardiac malformations, most fetuses with congenital heart disease will have a left axis deviation, and most are diagnosed in the 2nd trimester. Now, if cardiac access is really important, learning to look at the cardiac access is important in your evaluation of any 4-chamber view. So the normal cardiac axis, as you see here, is about 45 degrees. You know that the cardiac axis could be abnormal in cases of common arterial trunk. You see that it's almost 90 degrees in more than half of fetuses. In cases of tetralogy of Fallot, there will be significant left axis deviation in about 30% of cases. Transposition of the great artery, especially corrected transposition, is associated with mesocardia, where the heart is centrally located in the chest, and double outlet right ventricle also tends to have mesocardia, where the heart is shifted a little bit towards the central position of the chest. Now, this is in the second trimester. You have the ability to measure the cardiac axis in the first trimester. You have to use color Doppler because it's really hard to see the septum very early on. And we like the use of high definition color or power Doppler that highlights the ventricular septum for you very well. And you measure it in the same way you measure the cardiac axis in the second trimester. And you can see with 2D, it's very difficult to see the ventricular septum. Conventional color Doppler is helpful, but high definition color Doppler is really the best in our experience to measure the cardiac axis. Now the fetus, it looks like from 9 weeks onward, assumes the position, the heart assumes the position that we know of in the second trimester and beyond, with a 45-degree angle plus or minus 20, as you see right here. And you can see this from 9, 10, 11, 12 weeks onward. We did a large multi-center study looking at the value of the cardiac axis in the first trimester in the detection of congenital heart disease. And you see in blue here are fetuses that are matched controls 2-to-1, and the red triangles are fetuses with congenital heart disease in the first trimester. 197 fetuses with congenital heart disease matched to 394 controls. First, if you look at the blue fetuses, the control fetus, you see that the cardiac axis barely changes, if at all, in the first trimester. And the cardiac axis is about 45 degrees. So the cardiac axis in the first trimester is very similar to what we see in the second trimester. And you can clearly see that fetuses with congenital heart disease tend to have an abnormal cardiac axis. And here are 3 cases: double outlet right ventricle, mitral atresia with a double outlet right ventricle, and tetralogy of Fallot. And you can see the cardiac axis are all abnormal. So when you look at the data in our study, you see that when you look at the nuchal translucency greater than the 95th percentile, detected about 19% of congenital heart disease. When you look at the nuchal translucency greater than 3.5 millimeter, detected 10%, but the cardiac axis detected 72% of congenital heart disease. So it is really important to look at the cardiac axis. It is a more important screening parameter in the first trimester for congenital heart disease than nuchal translucency, tricuspid regurgitation, and ductus venosus combined. So what we do, we don't measure it every time, but we look at it. When we see it is abnormal, we measure, and we do a more detailed evaluation of the fetal heart when we suspect that the cardiac axis is abnormal. This is a case presentation to show you. 33-year-old, she was referred for a first trimester ultrasound because the nuchal translucency was enlarged. She was at 12 weeks. And here's the 4-chamber view without color. It's hard to see. The cardiac axis is here, the spine is here. So there seems to be a significant cardiac axis deviation. But when you add color Doppler, first of all, you see the 4-chamber view, you see the axis very well. So you know that this is a significant cardiac axis deviation, as you see right here, almost 90 degrees. So we are suspicious that there's a problem. When we look at the outflow tract, the LVOT, we see that Y sign that I showed you before, suggesting to us that there is tetralogy of Fallot at 12 weeks. And upon further evaluation, we see that there's aberrant right subclavian artery also. So the combination of these findings, certainly in the setting of abnormal nuchal translucency, we counseled the patients for these findings. There was a small omphalocele also and 2-vessel cord. She opted to have a CVS, which showed the Wolff-Hirschhorn syndrome, and she terminated the pregnancy at 15 weeks. So this shows you how important is the cardiac axis in the evaluation of the fetal heart in early gestation. So do not miss the diagnosis of a normal cardiac axis in early gestation. Finally, the 4th anatomic region, I'm going to talk a little bit about the ventricular septum to hopefully increase your ability to make the diagnosis of ventricular septal defects. Not that they are important per se, but because they're high associations with other fetal malformations that you can detect by finding a VSD and working your way to evaluate the heart more carefully. So this is looking from the right ventricle inside. You see the scree vena cava and viri vena cava, the tricuspid valve. This is the location of the inlet type VSD, muscular types VSD, and then you have the crista supraventricularis here that divides the right ventricle from the trabeculated portion and the smooth portion, that's the outlet. So the VSD that is under the pulmonary artery is called an outlet VSD, and the VSD that's under the aorta is called the perimembranous VSD. So these are the most common and the 4 types of the VSDs. And here you can see on the 4-chamber view, you see the inlet and the muscular type. And on the 5-chamber view, you see the perimembranous and certainly the muscular type. So here's an inlet ventricular septal defect. When you see an inlet ventricular septal defect, you should pause and you should evaluate for the presence of partial or complete atrioventricular septal defect, certainly the complete type, because that could be the first clue to the evaluation of the heart in the presence of an atrioventricular septal defect. So it's really an important VSD to look for and evaluate. Here's another inlet ventricular septal defect. Depending on the angle of the insonation, if you see right here, there is brightness to the ventricular septum here because of the echo enhancement of the ultrasound beam with the blood under. So that's really important. When you are in an oblique plane, a little bit oblique, you may not see that echogenic line at the tip of the VSD. Color Doppler is really helpful to confirm the presence of a ventricular septal defect because it shows blood flow coming from right to left and left to right, typically bidirectional because of the pressures in the first trimester. Classic muscular ventricular septal defects, as you see right here, you see the echo enhancement on this side here. Color grayscale may not be very helpful in the evaluation of the septum. You have to be as perpendicular as you can into the septum. That increases your ability to see VSDs. Now I know I'm suspicious, maybe there is something here, but look how helpful color Doppler is. Clearly shows the septal defect and shows, you could see that brightness in color at the level of the defect because of the increased velocity of blood through the defect. But also, if you look closely, the blood flow is bidirectional, going back and forth through that VSD. Here's another case of an apical muscular ventricular septal defect. Here you can see it clearly on the grayscale image, but you have to be suspicious to look for it. Color Doppler is very helpful in showing the diagnosis. Now, if you put your spectral Doppler over the VSD, as you see right here, you will see the bidirectional flow. And most of the time, it will mimic diastole, and systole will mimic systole, as you see right here. And in most ventricular septal defects, the blood flow will be bidirectional. Perimembranous ventricular septal defect are noted, as I mentioned earlier, at the 5-chamber view, at the LVOT view. Here you have to make sure you don't have an overriding aorta, so it's not easy when you have a defect that is that large to make sure that the aorta is not overriding over the septum. So you have to look from multiple planes. Again, this is on grayscale here, showing you a suspected VSD here, but the aorta appears to be totally within the left ventricle, and also the angle will be a little bit preserved. And when you add color Doppler, again, you see that the angle is preserved here, telling me this is not an overriding aorta, but rather a perimembranous ventricular septal defect. Now, the outlet VSD is rare. This is the most important plane in my experience to make the diagnosis. This is the normal short axis view, showing you the left ventricle, the right ventricle, and the pulmonary artery coming out. And here's the septum that you need to evaluate. And here's one case with outlet VSD, and here's another case with outlet VSD, and you see the defect in the ventricular septum right under the pulmonary valve. And again, color Doppler will certainly show you blood flow that is bidirectional. Here it's going during systole into the left ventricle, and during diastole from the left ventricle back through the defect into the right ventricle. And here you see again the defect, and if you look closely here, you see the bidirectional flow. Again, you see the blue and the red coming through the defect. So do not miss the diagnosis of a ventricular septal defect. How do I evaluate ventricular septal defects? I suspect them on grayscale. I always add color Doppler. I try to align myself perpendicular to the septum. If I see blood shunting, if I don't see blood shunting, I bring the patient in the third trimester for reevaluation. If I see blood shunting, I confirm the presence of ventricular septal defect. Now, where is it on the septum? The inlet type, assess the integrity of the atrioventricular valves to make sure you don't have atrioventricular septal defect. The muscular types are easy. They're not associated with genetic abnormalities. We just follow up postnatally. Perimembranous one, you need to look for aortic override to make sure you are not dealing with tetralogy of Fallot, common arterial trunk, or double outlet right ventricle. And the outlet ones are rare, are difficult to detect prenatally, but certainly are important to look for. So do not miss a diagnosis of a normal ventricular septum. So what I've shown you during this presentation, how important it is to look for the normal left atrium, because you can then rule out total anomalous venous return, isomerism, interrupted IVCs, and other. I showed you how important to look for the normal ascending aorta, because then you rule out tetralogy of Fallot, transposition of great arteries, double outlet right ventricle. I showed you how important to look at the normal cardiac access in early gestation. That can help you to rule out a significant proportion of congenital heart disease in the first trimester, and the normal ventricular septum, because VSDs are commonly associated with other fetal malformations. I want to thank you very much for your attention. I want to thank my friends for inviting me, Karine and others. And I want to just put in a little bit of advertisement for a free ultrasound book. Is on openultrasound.com. It's a free ebook that talks about OB and GYN ultrasound and has been translated to more than 11 languages. So thank you very much for allowing me the opportunity to speak, and I will be happy to address any questions. Thank you.
Thank you, Alfred, so much for your talk, your great talk. I really appreciate the way that you stress the importance of diagnosing a normal plan in different levels, and then to making the differential diagnosis about the abnormality that you see. I think it's really important even for the less experienced examiner. So we are going to address some questions from the audience. The first one from Alexandra Iskrovskaya. I hope I said your name well. Do you have any criteria to differentiate physiologically narrow aortic isthmus from coarctation in late gestation? Any measurements of the isthmus, comparison of the isthmic width to the width of the descending aorta, isthmic velocity flow cut?
Okay, yeah, thank you. Very important question and really difficult to answer, because coarctation of the aorta is not an easy diagnosis to make. Sometimes in the third trimester, and has a fairly high associated false positive and false negative rates. Also, when you look at the aortic isthmus could be impacted by other causes other than coarctation of the aorta. As Rabia has said in his three-vessel trachea view, could be impacted by changes that happen in the heart or in the ascending aorta. Also, it's important to note that the aortic isthmus could be impacted in cases of fetal growth restriction, where you will have narrowing of the aortic isthmus due to shunting of blood, to the brain and to the heart. So what I look for in coarctation of the aorta, certainly it is suspected by discrepancy in the ventricular system, and the left ventricle being smaller than the right. I look at the aortic isthmus. If the aortic isthmus is small and there's reverse flow, or if it's small with forward flow, then I'm suspicious of the presence of coarctation. I look at the aortic arch. If I can get a clear view of the aortic arch and demonstrate a narrowing at the aortic arch, I can then make the diagnosis of coarctation, but always with a statement that says that this diagnosis is associated with fairly high false positive and negative rates. There are charts to measure the aortic isthmus with regards to its size, color. The pulse Doppler will show increased velocity through it in the presence of narrowing. But typically in my lab, we rely on visually seeing a small aortic isthmus and looking at the color Doppler to make the diagnosis rather than more specific measurements. There are no cutoff that I know because it depends on the severity of the coarctation and severity of whether the whole arch is tubulary, small, or it's a focal segment. So there are no critical measurements that differentiates cutoffs between yes or no.
Great, and it leads us to our next question. Many colleagues asking for some tips for the use of Doppler in different planes, either color or spectral Doppler. So how do you set up and to diagnose the different
Yes. So I strongly recommend that you use color Doppler very liberally in your evaluation of the fetal heart. It is really extremely helpful. The heart is a dynamic organ that is really based on the flow of blood from one chamber to the other and one chamber to an outflow tract. So we use color Doppler always on every single ultrasound that we do, whether it's basic or doing a fetal echo in the evaluation of the fetal heart. I strongly recommend to do so. Know how to adjust your color Doppler to improve your visualization, improve your frame rate in looking at the fetal heart. I believe it is essential. Pulse Doppler may not be essential to use on the basic cardiac screening, and I don't think you need to use it if the color Doppler is normal. The new fetal echo guidelines that were just released by the AIUM and many societies in the United States have added, for the first time, pulse Doppler at many different levels. So it is at the AV valves, and then at the semilunar valves, and then certainly looking at at least one of the pulmonary veins because of the reasons that I mentioned, because of the abnormality in the pulse Doppler when there is anomalous venous return. So color Doppler, yes, all the time. Color Doppler is essential, in my opinion, in the first trimester to do cardiac screening, to get it at the 4-chamber view and the 3-vessel trachea view. Pulse Doppler, I would say no for cardiac screening, unless you suspect an abnormality. Certainly yes, as part of the fetal echo exam.
Thank you. And a question from Dr. Rambul Seski from Haifa. Here in Israel, we perform our early scans, preferably using transvaginal route, either at the time of the nuchal translucency, but here more often between 14 and 17 weeks. So we would be happy if you tell us your opinion on the contribution of the transvaginal route for the early diagnosis of the cardiac anomaly.
Yeah, so very important question. I would recommend that what we do is we do our first trimester screening between 12 to 14 weeks, a little bit earlier. And around the time we do the nuchal translucency. And the reason for this is once you cross 12 to 12 and a half weeks, with the equipment that we have today, you really are able to see what you need to see to do a cardiac screening examination in the first trimester. And what we recommend to do is doing a 4-chamber view with and without color, and a 3-vessel trachea view with color. And that the 4-chamber view, the importance is to make sure that the ventricles have equal inflows into them. So we're not dealing with the hypoplast or AV septal defects. And we look at the cardiac axis, as I shown, because it is a very powerful screen for congenital heart disease in the first trimester. And the 3-vessel trachea view is critical to the evaluation of the outflow tracts. The LVOT plane is difficult to get in the first trimester. It's a very thin plane, And I don't think it is that helpful because it's really hard at 12 or 13 weeks to look at aortic override and so forth. But the 3-vessel trachea view is fairly easy to get. And it shows the relationship of the great vessels. So at least you can get some good reassurances for that. Now, most of our exams are done transabdominally, and we are able to do this cardiac screening in the first trimester transabdominally in more than 90% of the time. When we are not able, and we see that the transvaginal approach is going to be successful, meaning that the fetus is mostly in a transverse position, where if we go transvaginally, we get very close to the heart, then we add that. Anytime we suspect a fetal malformation in the first trimester, we always do a transvaginal to get better images. So my recommendations, based on our experience, and we have been doing first trimester screening now almost for 10 years, is to, first of all, move your screening earlier at the time of the nuchal translucency, because then you avoid having the patient to come twice. Use the transabdominal approach. If you optimize your ultrasound image, you are able to really do good cardiac screening, but also good fetal malformation screen in the first trimester from 12 weeks on. And thirdly, use color Doppler in the evaluation. Now, when is the best time to do it? Based on the literature, somewhere around 13 to 13 and a half weeks seems to be the sweet spot, because if you look at the detection of fetal malformation, the curve goes like this and then flattens a little bit around 13, 14 weeks. Certainly between 12 and 13 weeks, it's still an upswing. So getting to 13 to 13 and a half weeks probably is the most optimal time to do cardiac screening in the first trimester. Early enough where if you find the malformation, the patient can get a CVS and you can get the results fairly quickly. And the detection of malformations between 13 and a half and 14, 15 weeks probably is not that large, given based on the literature that is available today.
Okay, if we were live now and you were here with us, now you would see our Israeli colleagues, half of them saying first trimester, 12, 13, and half saying 14 to 17. So you would see some emotion on this topic, and that's why we have...
I would recommend the half that is on the 14 to 17 to try it. Get the expertise and try it. You will be very pleasantly surprised that you can really complete your cardiac evaluation very easily. And I will tell the group that are on the 14 to 17 weeks that there are new guidelines that were just released from the AIUM, I think last week or 2 weeks ago, on the detailed first trimester ultrasound exam. And these guidelines are in the United States indication driven, because we still have to find an indication in the US to do the first trimester screening, unlike in Israel or in Europe. But this document goes into details of what to look for in the first trimester, and it's focused between 12 and 13.9 or 14 weeks. So this seems to be the area, the gestational age window, where the first trimester ultrasound will be recommended or is recommended now. And most studies in the literature have been done in this gestational age window. So my recommendations for the group that are on the higher end of the gestational age is, please trust me, look at the literature, look at the large studies that have been done with tens of thousands of patients, and try to move your screening. We're only asking to look at the 4-chamber view, cardiac access with color, and the 3-vessel trachea view.
Thank you. I think our main division also includes when is the best time to see the fetal brain. And then I don't think we would convince the brain people, including me, to that 12 is better than 14. But I think here in Israel, we have an opportunity different from other places to see the patient at least 3 times. So this is routine. Coming from nuchal translucency, then between 14 and 17, and this is, I think, procedural regarding the local recommendations. In most countries, I think it's not feasible to come so many times for scan, and then of course, I think you shouldn't miss the opportunity to make an anatomy scan in the first.
And I think, Karina, it is. I would say it is certainly is better to do from an imaging perspective. Clearly, it's better to do it at 14, 15, 16 weeks, right? Because you see more. I don't have to convince anybody that the further up you go into the second trimester, the more you can see. But it's a balance. It's a balance between, do I make a diagnosis of a hypoplastic left heart at 13 weeks versus 15 weeks for a patient? Because at 15 weeks, you're talking about counseling, maybe a genetic test, then you are doing a termination at 17, 18 weeks. Whereas at 13 weeks, you're doing the termination at 14 and a half weeks. And there's a difference in that. And then with regards to safety and with regards to emotional aspects, of the patient, because at 12, 13 weeks, the patients typically, they have not announced their pregnancies out, to their friends and family. So it's a more private issue to deal with. The other aspect that I think is really important is with the NIPT now and the cell-free DNA results that could be done at 9 weeks and 10 weeks, we have a lot of patients coming with abnormal cell-free DNA that require an ultrasound. And should we tell them wait until 14 weeks for us to be able to see, or let's look at 12, 13 weeks and then look at the anatomy at that time? So, and in the United States, and I don't know what will happen in the future, but there is a push to limit the ability for offering termination for pregnant women lower and lower in gestation. There are some states that have gone below 20 weeks and are coming closer to 14, 13 weeks. So the ability to do an anatomy survey early on, understanding the limitation of it, could be helpful for reproductive choice also.
And regarding early diagnosis, how do you investigate early VSDs? So do you really address them as artifact, or probably they will disappear? How do you address them?
Yeah, so we don't look for them, but if we see them, we tell the patient that, especially if they are muscular, that there's a very high chance they're going to go away. We don't make a big deal out of them, certainly, and we follow them. And a lot of the ones we identify in the first trimester heal on their own or close on their own when we see them later in gestation. Now, a VSD that is an inlet VSD in the first trimester is important to evaluate for the presence of atrioventricular septal defect. So here we look at regurgitation across the AV valve. We look at some of the markers to suspect the presence of AVSD early on, but we don't really look for them. What we are looking, Karina, in the first trimester is really, are the ventricles equal in size? And is there equal flow across the ventricles? Meaning we don't have hypoplast right or left. We don't have an AVSD. Is the cardiac axis normal? And are the vessels at the 3-vessel trachea view normally oriented? And that's really what we are looking for.
And our last question from Dr. Ron Bardeen. Do you have tips to demonstrate the coronary sinus? And how do you recognize the dilated coronary sinus, for example, imitating CAVC? What differential diagnosis should be taught and looked up?
So the coronary sinus is best viewed in a plane that is slightly inferior to the 4-chamber view. So from the 4-chamber view, slide a little bit lower, you will see the coronary sinus, and it looks like a line that is running across the AV valves, a little into the atria across the AV valves. When it is dilated, this line appears to be enlarged, and that's the best way to look for it. Now, most of the time, a dilated coronary sinus is a reflection, most of the time, of a persistent left superior vena cava. So, and the persistent left superior vena cava looks like an additional vessel that is attached between the left atrium and the left ventricle at this junction where the annulus is, a little bit on the outside. It looks like there's a ring that is sitting at that side. And that should be the clue also to the presence of a dilated coronary sinus. If you are in the habit of looking at the brachiocephalic vein, as Dr. Shawi had shown today, by sliding up into the chest, if an absent brachiocephalic vein should always be a strong marker to the presence of a persistent left supravena cava and then a dilated coronary sinus, because that's the most common association when there's an absent left brachiocephalic vein.
Alfred, thank you so much for your participation and your input on this very important topic.
Thank you.